It's a pleasure to get the chance to speak about this with you. Anybody who's does anything in the medical field has probably observed the last several years that young people all of a sudden are getting colon cancer. I have been a doctor in some capacity for 23 years, and this has noticeably changed even within the last 10 to 15. When I was a medical student and starting out my practice, the only people that we would see generally that were under 50 with colorectal cancer were those that had a clear familial syndrome. But now, even though numbers say across the country it's about 20% of colorectal cancer patients, meaning about 20% of patients are under the age of 50, I would say my practice is actually pushing about 30. So very common problem, and it's a reason for alarm, and I think an excellent opportunity to share the latest and greatest about all this. If there's any questions during this presentation, totally happy to stop at any point, but I hope that you find this interesting and engaging and as fascinating as I do. So the objectives of my talk, I want to discuss the trend of increasing incidence in early onset colorectal cancer, which we generally refer to that as EOCRC, recognize symptom recognition, screening options, as well as the best diagnostic tools. Review the most latest and greatest in the NCCN, which is kind of like the Bible of cancer for colon and rectal cancer treatment. And then also talk about some of the special considerations that we weigh in when it comes to treating the early onset population.
Dr. Logue, if this is Janet Bloom, I'm the director of AHEC. I was just wondering if, sorry to interrupt, but are you moving on your slides at your end? We only see the same slide, the title slide.
I appreciate you doing that. Letting me know this. I am scrolling through, and on my end, it looks like it's scrolling. Is that not the case on your end?
Yeah, we just see the, I believe this is an email which has an attachment.
Okay, no, thank you for letting me know that. Let me see if this will help. Did it change now?
You are scrolling, but it's still the email. I don't know if you want to unshare and start over. That may be quicker.
Okay.
Let's see.
How's this?
That's perfect. We're on objectives. Thank you.
Fabulous. Okay. So these are the objectives. I just want to really review some dates and then also talk about some of the special considerations that we, need to discuss with our early onset population. So colorectal cancer is the third most common cancer in the US, with it being the second leading cause of cancer death. So risk is, for women not as high as breast cancer, but it's still relatively substantial. So about 1 in 25 women and 1 in 23 men get it. What we do know is that we have to take in consideration about how the efficacy of screening has, changed the distribution of our diagnoses. So what we do know is that we've been screening for colorectal cancer in the 50 plus population for many years. So that has actually reduced the incidence in older adults, but for a couple different reasons, it's not been as efficacious in the younger adults. So what is early onset colorectal cancer? It is someone who's diagnosed before the age of 50. And even though the numbers state that it's about 10 to 12% of all colorectal cases, there's some areas in which it may be on the upside of 25+%. And we know that it's not just in the US, that it's actually worldwide, that the rates are increasing in the, millennial population, now even going down to Gen Z, but as well as, the younger Gen Xers. And because of screening, the rates are actually decreasing in patients over 65. What we know is since the 1990s, colorectal cancer incidence in adults under 50 has increased by 50%. And interestingly, the distribution of cancers in young throughout the colon and rectum is not the same. So rectal distal cancers, meaning Those in the rectum and the last few feet of the colon are actually more common in young, disproportionately so compared to older patients. And interestingly, I've read this is actually about 130+% chance that if you're born after 1990, that you develop colon cancer before the age of 50 compared to the cohorts that are born prior to 1970. So it definitely raises a question that makes us curious is what's changed. The greatest increases have been seen in the ages of 20 to 39, and it's estimated that by 2030, colorectal cancer will be the leading cause of cancer death in adults under 50. So this is definitely a big problem. What we know, so what's the difference between the cancers in the younger and older? Is there really any difference? What we do know is that young patients are more likely to present with the distal tumor, so less common, they're going to come in with a right-sided or transverse colon cancer. Rather, it's more likely sigmoid or rectum. It's more likely to be locally advanced or present as stage 3 or stage 4, which we know stage 4 basically is metastatic disease or disease that's progressed to other organs outside of where the tumor originated. There's also a part of this that we think reflects really the delays in recognition and referral. We know that even though multiple societies have changed the recommendation for screening to from age 50 to 45 within the last several years, the under 45 population that's average risk is not routinely screened. So that does contribute to some selection bias. We do know that ethnicity does play a role in regards to how mortal the cancer is, as well as the distribution throughout the colon. African Americans tend to have a more aggressive variant of this throughout life, but unlike young patients of other ethnicities, young African American patients don't just have the disproportionate distribution of colorectal cancer in the rectum and sigmoid. Rather, they can get it about equally distributed throughout the colon. Why does colon cancer tend to behave more aggressively in African Americans? It's likely multifactorial. There probably is some level of genetic variation, but also other issues with healthcare disparities as well as access to care that contribute to that. Then we also wonder, is this the same cancer in the young population versus the older? So a couple different things have been studied to try to elucidate that. So really to summarize it briefly, if a person's over the age of 50, their average risk and they develop colon cancer, there's about a 15-ish% chance that there's a hereditary syndrome, meaning they were born with some type of mutation that led them to have an increased risk of cancer. And that mutation is something they inherited from their parents, but then also is something they could pass on. So relatively, low percent of colorectal cancers are, related to inherited syndromes. It's a little bit higher in the young population, but interestingly, not dramatically so. And some of that probably is because in a young person, diseases like hereditary non-polyposis colorectal cancer syndrome, as well as APC, which is the genetic syndrome where patients get thousands and thousands of polyps, those cancers tend to present at a younger age. So that probably accounts for some of that higher rate of inherited phenotypes. However, even in the young population, sporadic cancers, meaning we can't, at least from a inherited standpoint, elucidate exactly why the patient developed the cancer. Sporadic variety is more common. There are different mutations now, and this is to me one of the most exciting things about practicing cancer care that's really evolved in the last 10 to 15 years is we know more about the importance of identifying genetic variants on all cancers, and that helps us prognosticate the cancer. We know that some of these genes that I have listed, that when mutated, they may curtail somebody that's going to have something that behaves more aggressively versus less aggressively. It also lets us tailor the treatment. So some of these mutations will allow a patient to be very, very sensitive to things like checkpoint inhibitors or immune therapy, where others, pretend a poor prognosis or insensitivity to different types of treatments. So we really would love to know an answer about why, the younger population is developing this. But in short, we don't really have a clear-cut, culprit in which we could really point the finger at that has been strongly tied to the increase in incidence. But we know the obesity epidemic is definitely part of what's going on. And this is always something, it's a difficult thing to discuss with patients. I've always tried to approach it in a way that you don't impugn them personally, rather, say, this is what the specific issues that obesity can cause in related to or in relation to you developing type 2 diabetes and what the short and long term health problems are with that. Obesity is interestingly a pro-inflammatory state. So it really, and as a surgeon, we appreciate that in a unique way because you can even when you handle tissue operatively, the inflammatory changes and how it handles is different. So it does make you kind of give you hands-on references to why obesity does or what the consequences of the inflammation are. So the other thing I tell people is obesity is technically a carcinogen. So we know that obesity increases the risk substantially for at least 5 different types of cancer, colorectal being one of them. So it's stuff that I tell patients, that whenever we talk about weight loss, it's not to impugn you or, fat shame or anything like that, but rather it is a health problem. When your body is kind of, for lack of better terms, cranking at this chronic pro-inflammatory state, there's a lot of physiologic consequences to that, one of which is increase in the incidence of various types of cancers. We do know that red and processed meat in excess is likely linked to some level of chronic colonic mucosal damage and increases the risk. Now, that being said, our bodies are, in my opinion, amazingly resilient and able to handle small amounts of toxins. We, are exposed to things every day that if we, took in high doses would be fatal, but, we're very resilient in a lot of ways. So while I don't discourage people to totally eliminate red meat or processed meat from their diet, I do talk to them about, just trying to keep those things as a occasional treat and not, a part of your daily staple. We think that low fiber may be an issue. And so we know what fiber does is it binds to the toxins in what we eat. And we believe that the fiber kind of binds to the toxins in a way that protects the colon mucosa from the oxidative stress. So in turn, less exposure to toxins decreases the risk of the mucosa developing polyps that can then grow into cancers. Low calcium has also been associated with the increased risk. And there's a lot of enthusiasm in regards to the gut microbiome, which with everything in modern life over the last 50 years has really substantially changed that. Another culprit, interestingly, is high fructose corn syrup. And this is not so much substantiated directly in humans, but it has been shown to increase the risk of colorectal cancer in laboratory rats. And so it's actually kind of fascinating. You think about what led to the rise of things like high fructose corn syrup and hyper-processed foods. When did that happen? So we know there was, food shortages in the 60s and 70s. And so with that came the interest in being able to produce, relatively inexpensive and affordable foods that will be shelf stable. So, as a consequence, foods basically we had to take some fiber out so that they would remain dry and be things that could sit on the shelves for longer period of time. Also, we do like sweets. That's I certainly am one of many that has a sweet tooth. High fructose corn syrup is basically a powerful yet inexpensive way to sweeten various things. And it's very ubiquitous. We think about sweet foods being, desserts or candy or even cereals. But you look at most items that we enjoy, even a pizza crust has high fructose corn syrup. So it's one of those things that kind of sneaks its way into our diet in many different ways. And those things really rose in the 70s. And if you think about the age range of patients in whom early onset colorectal cancer has become more prevalent, it would make sense this is the generation that was raised on these products. So, could account for a part of the discrepancy between the older cohorts. Diabetes is interesting. And that's something that with age, as a physician, I've really appreciated how awful of a disease this is. We think about it's something that a lot of us live with. But what really happens is you get an unopposed insulin growth factor, and that's actually does increase risk for cancer. So we know all the different things that diabetes can do in regards to leading to other types of end organ damage or failure. But I tell patients, type 2 diabetes is really quite a sinister disease. It's important you do everything you can to, keep that under control. We also know smoking, alcohol, and I'm actually relatively, let's see, I'm pro the anti-alcohol, alcohol-free lifestyle. I think that there's a lot of benefit to that. And alcohol in itself is a carcinogen. It's something that's been very socially acceptable for many hundreds and hundreds of years. And kind of going back to the point of how we're very, very resilient at handling small exposures of toxins every day. If you drink pure alcohol, that would be instantly fatal. So I do tell people, it's something that I hesitate to say the word moderation, but everything that we expose herself to is a calculated risk. Why I wouldn't say totally, go back to the abolitionist days, alcohol, and especially the generation in which that was really glamorized, that Gen Xers, baby boomers, maybe a little bit less so the millennials. Those things, when consumed chronically over decades, may have consequence. And then lastly, inactivity, and unfortunately, modern lifestyle pretends itself to that. We our culture in which to survive, that you may have to spend a lot of time, sitting in your car commuting. Or at jobs in which you're, mentally very active, but physically not so. And that's also thought to be an increased risk for cancer. We know that family history of colorectal cancer or advanced polyps also does increase someone's risk. And the general guidelines are, if you have a first degree family member that has a history of either advanced polyps or colorectal cancer, you should start getting screened at least 10 years before the age of when they were diagnosed. Now, if they are diagnosed older, that may not lower your screening age, but say your mother was diagnosed with colon cancer at 49, it's important for somebody to know their screening should start 10 years or prior to that. There are a couple hereditary syndromes that are, known to be associated with early onset. So hereditary non-polyposis or Lynch, a lot of folks have heard of that. And that's actually the most common identifiable genetic syndrome associated with early onset. And not only does it increase the chance you develop a colon cancer, it does increase the chance you develop something called metachronous, which means you get a colon cancer today, but you're higher risk later on in life to develop a second unrelated colon cancer. It also puts people at risk for other types of cancers, such as endometrial, bladder, and gastric. And then familial adenomatous polyposis syndrome is called FAP. And that is a syndrome in which patients it's an autosomally dominant inherited syndrome where they get thousands of polyps in the colon and rectum. And the chance they develop colon cancer by the age of 40 is almost 100%. But those two diseases, while they're the two, famous syndromes associated with colorectal cancer that's inherited, do only account for just a small minority of the cancers that we're seeing in the young. Inflammatory bowel disease is a risk factor. Length of duration to how long they've had the disease, as well as how severe the disease is and where the disease is located, does play a role into the risk associated with UC and Crohn's. But the presence of either of these also does change screening guidelines. And so, touching back on what we talked about in regards to the dietary issues, we know low fiber, lots of processed, items in our diet. Somebody recently I was speaking to put it nicely and said, "Well, we eat chemicals," and I thought, "Oh, that's true." If you look at the back of the labels of a lot of things we eat, and you do think, are we starting to realize the consequence of that for decades? There's one thing that I think is actually really fascinating that maybe better illustrates the issues with being sedentary in modern lifestyle in regards to early onset colon cancer and the distribution of that being distal. And it comes from a doctor named Dr. James Church. He is a surgeon up at the Cleveland Clinic and is thought to be kind of one of the gurus in expertise for early onset colorectal cancer. And he's got a theory, and it's a pretty interesting one. So his question is, why do young people have distal cancers? Meaning, why are they getting rectum and sigmoid and not so much right colon cancers? And why has that changed since the 1970s? And he attributes it to lifestyle changes, which became increasingly reliant on being sedentary, meaning we're sitting in our car commuting, we have office jobs in which we're sitting in front of a computer. While we come home from work, we feel mentally exhausted from sitting in front of the computer and having all that simulation all day. Realistically, we're very physically sedentary. We also are in workplaces in which, socially it may not be easy or convenient to go to the bathroom when you have the urge to do so. So you think about, what do all those things lead to? It leads us to hold our stool in until it's a convenient time to go to the bathroom. And that probably is much longer than it was 100 years ago, where when people, developed the sensation to have to evacuate, they were pretty much, are able to go to the bathroom at their convenience. Where now, for multiple reasons, people tend to hold on to stool longer. Where it sits when that happens is the distal colon and rectum. So the mucosa of the distal colon and rectum have a longer exposure to the toxins in the stool than they used to, which may help to account to why young people get distal cancers. That being said, we like to try to problem solve and, help people and figure out what's going on so we could do something about it. But unfortunately, there's still a lot of ambiguity of this, and we really don't have a lot of identifiable causes. And a lot of patients, we still see a lot of people in our practice that are under 50 with no family history, otherwise a healthy lifestyle, and they still get this. So we still are lacking for clarity. The other thing that can be tough is patients who have early onset oftentimes present advanced, and that's because the symptoms are usually vague, and it's stuff that you think in the context, thinking about, say, a 35-year-old, they have their job, they have young kids, they're busy, and just life is really kind of coming at them 24/7. They may have, mild irritable bowel syndrome type of symptoms, meaning a little bit of GI upset that may be variable in regards to diet and stress. We oftentimes see a little bit of blood when we go to the bathroom, but I think it's more common for a young person to say, yeah, it's probably just hemorrhoids, and then not maybe follow up on that. Diet, unfortunately, with the hectic lifestyle we live comes a diet that lends itself to convenience. So we're not, younger people aren't eating the best foods, and that may, we eat, it's amazing the stuff that we eat that has calories to transiently sustain us, but does that really do our GI tract the best service? And does it at times wreak havoc where, we eat these greasy, spicy, sugary kind of heavy foods that cause some stomach discomfort, and people just think, well, that's, I just ate something that didn't agree with me. So that a lot of these things are appreciably related to just lifestyle issues, and also thinking that some of these mild symptoms aren't really anything that could be sinister. But then also, interestingly, we've seen this that ladies have a baby, and it's common during pregnancy that your hemorrhoids will get engorged and very swollen. And there may be some issues with hemorrhoidal flares and hemorrhoidal bleeding in the during the pregnancy as well as the postpartum weeks, in which a person thinks, well, my hemorrhoids acted up, it's normal. But we do see this once in a while where that's the way that they knew that there is something going on, is postpartum bleeding that didn't resolve. So the other symptoms related to colorectal cancer do have a lot of overlap with what we see in older adults. So rectal bleeding, change in bowel habits. I always tell people, if if you've had a change and it's more than 4 weeks, that would indicate that something may be going on, meaning that we get GI bugs and different things that can alter our bowel habits. But if it self-resolves in a couple of weeks, that's usually nothing to worry about. But if it persists, it's reasonably get it worked up. And maybe somebody that presents with new onset abdominal or pelvic pain. Iron deficiency anemia, and that is something I think will warrants further discussion, as well as fatigue and difficulty with exercise tolerance. Interestingly, in my practice, I would say that's actually one of the more common presentations of a colon cancer in a young person, or unintentional weight loss. So you think about the issue with colorectal cancer is it will slowly bleed. So you're not losing massive amount of blood on a day-to-day basis, but you lose this very small amount of blood. Tumors are friable. They almost to me look like a piece of red cauliflower, and you touch them, they bleed very, very easy, but they don't bleed a lot. So a person may have one of these things. It's, advanced polyp, it's progressed into cancer, and they walk around with that and are losing a small amount of blood every day for months. What that will cause is an iron deficiency anemia, and it may be that they can compensate that for that very well because they're young, they have good cardiopulmonary status, so they may have to get really pretty profoundly anemic before they're symptomatic to the point that they say, boy, there's something wrong. I have one patient who's fortunately 3 years out now, but he was the best man at one of my former residents' wedding. Just a delightful person, great sense of humor, really nice guy. He was a firefighter, and that was his manifestation. So a couple years after I attended her wedding, she called me and said that he had been training for a marathon and would run, in addition to that, just frequently run with his friends in the fire department, and would notice he couldn't keep up. And that's how they ended up finding out he had a hematocrit at 28, iron deficiency anemia, then ultimately did a colonoscopy, found a right colon cancer. It ended up being stage 3. He underwent adjuvant therapy and fortunately remains disease-free, but a very frightening diagnosis for someone that was 31 at the time. And so when should you worry? Rectal bleeding that persists for more than a couple weeks, bowel habits that, basically are totally different for you that last for more than about 2 to 4 weeks. And again, I think the iron deficiency anemia that has no other explanation warrants endoscopic evaluation, or any type of family history. So, in regards to screening, one thing I wanted to make a point of is we talk about the screening age being lowered to 45, and that's average risk. But average risk to me is kind of not really a specific term, but average risk basically just means somebody, they have no personal history of anything like ulcerative colitis, Crohn's disease. They're asymptomatic, meaning they're not coming and telling you, I have pelvic pain and bowel habit changes. They don't have family history. So it's somebody who basically has no risk factors whatsoever. They're asymptomatic. Um, that patient population should be screened at 45. So the screening options, it's, I think one of the favorite quotes in the colorectal community is the best screening test for colon cancer is one that somebody will actually do. Colonoscopy, that's considered our gold standard. We like colonoscopy because it isn't just diagnostic, but it's therapeutic, meaning we know that most sporadic colon cancers start from polyps, and it takes anywhere from about 6 to 15 years from the time the most common type of colon cancer starts as a polyp to the day it develops into a cancer. So that's actually a pretty long time frame. And so we believe that by doing colonoscopy, you find these polyps when they're small, you remove them, you pretty much stop them in their tracks. So that's how it can be therapeutic. Colonoscopy is a good test, but I do think it warrants discussion that it's not perfect. I've performed thousands of colonoscopies in my career, and it's interesting. I do colonoscopies, I do gallbladders, I do lumps and bumps, I do giant cancer operations for locally advanced rectal cancer. Colonoscopy is actually a really hard thing to do technically. It's something that I think is, for physicians, it's further complicated by anatomically, it's not that hard to understand what you're doing. You're looking through the colon and you're trying to get from the rectum to the ileocecal junction. Physically making that happen is actually hard. And a lot of people, even though we only have a couple anatomically described flexures, the hepatic and the splenic, it's interesting that about most people have an average of about 8 to 10 flexures, which means sharp turns throughout the colon. So physically making it happen and being able to look across these really tight angulations is challenging. So detection rate is not 100. So I tell people that, we do this, and even if we don't find anything, maybe we recommend that your next scope will be in 5 to 10 years, but it's not perfect. If anything comes up, um, that would raise concern that there is a development of some type of colorectal pathology, I would still encourage them to, consider a screening colonoscopy, shorter than when otherwise recommended. The other issue is patients do see it to be a violating procedure. It's something that, you have to take a couple of days off work to take the bowel prep as well as, do the procedure itself. So, that does weigh into their decision making as to whether or not they'll accept having a colonoscopy. And it is unfortunately the one screening test that we have for cancer that the risk of mortality is greater than zero, meaning you perforate someone or you have an anesthetic complication from a colonoscopy, that in rare cases can be fatal. Fortunately, I can't say I've ever seen that, but I understand in theory how that can occur. Then comes the fit Cologuard. A lot of endoscopists kind of turn their nose up at this and aren't the biggest fans. So what does it really do? So it looks for microscopic blood in the GI tract that specifically comes from colon polyps and tumors. It also looks for the abnormal DNA that advanced polyps and tumors make, which effectively is a KRAS mutation. So, and it's actually pretty good. So colonoscopy is 95% sensitive at detecting advanced adenomas and cancers, where a fit in Cologuard, meaning you're testing for the blood as well as the DNA, actually has a 92% sensitivity rate. So it's pretty good test. And if it's something that someone, is willing to accept this and not a colonoscopy, I think this is reasonable. Some things to bear in mind, though, is it's not appropriate if you have a history of polyps or anemia. So the test is not recommended for that. So this is really just for someone who's truly average risk. The other thing is you can actually get false positives, and I've seen that before where somebody has a positive Cologuard and then they get scoped and it's negative. And then lastly, it's not therapeutic, meaning if it is positive and the person truly has a polyp or a mass, there's, the FIT test can't do a polypectomy or biopsy it, so a colonoscopy still needs to be performed. CT colonography, I also think it's a good alternative. I do think that there's a couple things people need to know about that is even though you don't have to undergo the procedure of colonoscopy, you still have to take bowel prep. And that's sometimes a part of the reason why people don't want to do a colonoscopy. So it's important they're compliant with that and understand the necessity. If the prep's good and you have a radiologist that's comfortable with reading this, it can actually be very sensitive at detecting lesions that are a centimeter or greater. The downside is there's a lot of variability with how good the prep is. And, there's some radiologists that aren't comfortable interpreting this. So you'll get, a readout that comes back to be effective, didn't see anything, but we can't rule anything out. So it may not be very, the utility may be somewhat limited. Then lastly, similar to a fit colon guard, if you find something on CT colonography, certainly there's nothing you could do therapeutically. So it needs to be followed up with a colonoscopy. Other things that we do. So somebody comes in, there's concern for something like this, think about colonoscopy, just basic blood work. If you do find a lesion, then CEA is a helpful adjunct. It's basically a protein that some colon cancers make. While not diagnostic, it can be helpful in surveying somebody's treatment response, meaning if it goes to 0 after you do a curative resection and then it goes up a year later, then that may raise a red flag that there's a recurrence. The guideline recommendation is when you biopsy a colon tumor, so we do a colonoscopy, it comes back as what I call garden variety colorectal cancer, which is moderately differentiated adenocarcinoma. So the second thing that we always want to look for at that is confirm the biology. It's almost always adeno. Occasionally it can be neuroendocrine, it can be a GIST tumor, but assuming it's adeno, for about the last 10 to 15 years, we have routinely done mismatch repair testing, which also is known as microsatellite testing on all newly diagnosed adenocarcinomas. And for those of you that are familiar with what HNPCC is, we know that HNPCC is characterized by people that have microsatellite unstable tumors. So say, that patient I described, I do a colonoscopy on him, I get moderately differentiated adeno. If he comes back as microsatellite unstable, then I think, okay, this is somebody that I need to send to a genetic counselor and talk about germline mutation to evaluate for hereditary syndrome. The second thing that has a lot of utility is what we're really excited about, and probably one of the most revolutionary things I've seen in colorectal cancer treatment in my career is when a person is mismatch repair mutated or microsatellite unstable, they are sensitive to immune therapy and they will have a miraculous response to it. So there's a pretty good study that came out of Memorial Sloan that basically reviewed treating patients who have rectal cancer that are mismatch repair deficient with immune therapy alone, and the remission rate was almost 100%. So super exciting stuff. Now, the downside is we know that only the small minority of patients, which depending on what population you look at, 5 to 15% of colorectal adenos are mismatch repair deficient. So unfortunately, most are garden variety, meaning 85+% chance you don't have a mismatch repair mutation. But if you do, that does have implications in regards to consideration for workup for HNPCC, but also for the candidacy for immune therapy. This goes into mismatch repair testing in a little bit more detail, knowing that the mismatch repair proficients, the most common type of sporadic cancer, the mismatch repair deficient, or the MSI highs, microsatellite instability high, may suggest Lynch syndrome. And I do emphasize the word may, because some of the genes that are tested for when we look for mismatch repair mutations, some of these are more strongly associated with HNPCC. Interestingly, MLH1 is not. So say I get that patient's biopsy back, that comes back moderately differentiated adeno, but he's MLH1 mutated. I'm excited to think, well, he may be a candidate for immune therapy, but MLH1 can be mutated for sporadic reasons, and that's actually from acquired hypermethylation. The way that we actually test for that is you send something off called BRAF, and if that's mutated, then that suggests that the mismatch repair mutation was basically sporadically acquired and not germline. The other implication to wanting to know if your mismatch repair mutated patient has HNPCC is we know that Lynch syndrome or HNPCC has a pretty high rate of metachronous cancer in the colon, meaning person gets a right colon cancer today, but there's about a 40% chance there's another cancer is going to pop up somewhere else in his or her colon throughout their lifetime. So it's important to counsel patients of that and tell them, well, we could do a prophylactic total colectomy, which means taking out the abdominal colon rather than just a smaller segment if they have the interest in reducing their risk long term. Now, with that comes the downside of the more colon you lose, the more that's going to affect a person's quality of life and bowel habits. And so that goes into that further. I'm sorry, I could talk about this for 2 hours, but I don't want to get too bogged down in all that. What we do know, interestingly, too, and this is what being able to individualize uh, the genetic profile for each patient, why it's so crucial is it also helps us prognosticate. So even though we would think that microsatellite unstable tumors, that doesn't sound good, but interestingly, it's actually got a better prognosis. We know that if they're microsatellite unstable, they also tend to not benefit as much from fluorouracil therapy, which is a type of chemo that's commonly used to treat colorectal cancer. We do know that the pembrolizumab, nivolumab may also be very helpful in mismatch repair mutations. And so staging, say you get this patient, they're anemic, you find a colon cancer on colonoscopy, biopsy, garden variety colon cancer. You want to get a CT of the chest, abdomen, and pelvis, whether it's colon or rectum. For rectum, you also want to get a pelvic MRI. A pelvic MRI, rectum's a more complicated part of the large intestine, and that gives us some more details. And I tell patients kind of a better map of what's going on so we can best plan your treatment and surgery. And so I do, people talk about colorectal cancer, but I think they actually should be really described in two separate entities because the abdominal colon, which is where the small bowel and the appendix join in, all the way down to the upper part of the rectum, this lives in our abdominal cavity. So it's mobile and it's not too hard for a surgeon to be able to get to it, where the rectum's the last, give or take about 15 centimeters of large intestine. That lives in the confines of the bony pelvis. So it's just more difficult for us to get to. And it sits very close to other crucial structures. So the way that we treat it in the considerations we have to factor in are different. So, other thing we know about colon cancer is when we do surgery for it, we take out the disease segment several centimeters, before and after where the tumor is located. We know that it can travel lymphatic as well as hematogenously. So we take out the mesentery, which is the fat pad that surrounds the blood vessels and the lymph nodes of that segment. So with that, that helps us hopefully stop the cancer in its tracks as well as stage it. Removing a part of the colon, say you have a right colon cancer, you lose this very last part of small bowel, the first part of the colon, we take the lymph nodes with that, and we reconnect the last part of the small bowel into the colon distal to where we resected. It's pretty forgiving, meaning that the chance that heals can exceed 95%, so lower complications. It also doesn't tend to affect a patient's quality of life as much. So meaning I take out a part of the colon, whether it's right or it's sigmoid, a person may have somewhat increased frequency and looser stools for a while. The body's pretty smart though, and a lot of them will go pretty much back to normal within about 3 months or find that the change is very slight and not impactful on quality of life. So people tend to bounce back from colon cancer surgery easier than they do rectal. The rectum in this, I like this diagram because it kind of gives you the relations between all the important things in the pelvis. We know the rectum is the large part of the large intestine as well, but it's the last 15 centimeters and it's surrounded by the sacrum, the coccyx. Anteriorly, of course, in a man, you're going to have the seminal vesicles and prostate, the bladder. Anteriorly, there's the pubis. You just don't have a lot of room to work as a surgeon, technically, and it doesn't take much for a rectal cancer to grow, and then it's basically locally invasive into other organs. So our treatment approach to it is different, and it's much more complex than colon. Other thing with rectal cancer, when we diagnose it, is letting patients know, how long the treatment's going to transpire, what's involved in it. It does have a higher risk for major quality of life changes. When you dissect and operate in this area, there's about a 50% chance there's some level of urinary and sexual dysfunction, meaning they may have urinary incontinence, they may end up with difficulty voiding, they may end up with impotence, retrograde ejaculation. So all those things can be quite morbid, even though they're not life-threatening. There's also a much higher chance rectum is not nearly as forgiving as the colon, that a person ends up with a temporary or a permanent stoma. Lastly, radiation is a part of the armamentarium of which we treat rectal cancer with, and radiation does come with its own set of morbidities. And so briefly staging. So we know that for most cancers, if you have distant disease, that makes you stage 4. For colon cancer, it is staged based on how deep into the wall of the colon the tumor grows, as well as whether or not there's any of those lymph nodes in the fatty mesentery that are positive. And so we know that there's a lot of variation in regards to stage of cancer diagnosis and cure rate. So if you have stage 1, so meaning a tumor that went through much of the wall of the colon, there's no positive lymph nodes, and there's no evidence of disease elsewhere, the cure rate can exceed 95% with surgery alone. Or advanced stage, even though they may be able to live a good quality of life for several years, the cure rate can be only in the 10 to 15% range. And so that shows those statistics broken down. So one thing to bear in mind, though, is patients see this, and of course, you look at that and think that looks terrible. There's, only a 10 to 20% chance I ever am cured from this. But treatment has evolved quite a bit with this, that if they have fairly biologically sensitive and responsive disease, you can I have some patients that have been dealing with stage 4 disease well over 5 years. So it's not necessarily a death sentence, if you may, but rather it can be almost like a chronic disease, although ultimately there's, this cohort of patients is unlikely to ever have sustained remission or a cure. Rectal cancer, the prognosis is a little bit worse. Even for stage 1, cure rate's a little bit lower, but it's fairly similar to colon. And this just illustrates that the difference between prognosis and staging. So this is a really busy slide, but what we know is that early stage colon cancer, and I'm talking about the colon and not rectum at this point, that if you only take out the segment of colon and the lymph nodes, that the chance that person is cured if you're stage 1 is so high, we actually don't do anything else. Now, for stage 2, meaning it's a thicker tumor that doesn't have distant spread, nor does it have positive lymph nodes, stage 2 patients are still, really in pretty good shape in regards to disease-free survival. But depending on some biologic features, as well as what the tumor, what it presented with, meaning did it present with any high-risk features like obstruction or perforation at the time of diagnosis, may make it higher risk to recur. So there are select stage 2 patients that would benefit from getting some chemo after they receive a curative resection. We know that stage 3 patients, which are those that have positive nodes, are always going to benefit from getting adjuvant chemo. So we know adjuvant chemo just means chemo given after curative surgery. For colon cancer, that's generally FOLFOX, which is fluorouracil, oxaliplatin. They're pretty well tolerated. Some patients can get diarrhea, fatigue, some skin irritation. Interestingly, one of the things that bother my patients the most is sensitivity to cold, which comes with oxaliplatin. I'll have people tell me that cold is so incredibly painful when they do something like open up the refrigerator to grab a can of soda, they have to put gloves on. So it's important patients understand these side effects. Sometimes that neuropathy, unfortunately, can be permanent, and it may be something that needs to be considered in somebody that has a, highly manual job. What we know is for select stage 2 and stage 3 patients, with surgery alone, they may be about 50 to 60% chance that they will be alive in 5 years and disease-free. If you add on the adjuvant chemo, which is usually 3 to 6 months, that may increase the chance that they're alive without cancer from maybe 50 to 60% to closer to 70 to 80. So there's good talk to have with patients. This type of chemo is pretty well tolerated and it tends to be effective. So I like them to at least understand that this may be something that you'll be able to receive and still hold down your full-time job, do a lot of your normal activities. It doesn't tend to be the type of chemo that really just takes somebody out of commission. And this just further illustrates what colectomy means, partial colectomy versus total colectomy, where we take everything out. And then for surveillance, we know that these folks, I tell them, you're going to get to know me very well. They will get history and physical lab work, as well as imaging, usually every 3 to 6 months for the first couple years, but we do monitor them for 5 to 6 years post-curative resection. Everybody should get a colonoscopy within a year after their surgery. I tell them that, any person that has a history of this, even if it's sporadic, is always going to have a higher chance throughout their life to get more polyps or tumors. So it's really important that if you hit the 1 year mark, we do another colonoscopy. And you could see their interval at subsequent colonoscopies is, somewhat tighter than the average risk population. So rectal, I just want to touch on a few points because this is a really, really just tough disease. And unfortunately, it's a tough disease. It's more common in young patients. So rectum lives in the bony confines of the pelvis, and we know that it has a higher chance at recurring locally. It oftentimes involves a medical oncologist to give chemo, radiation oncologist, as well as a surgeon. What we do know is there's a couple paradigms for rectal cancer that have changed quite a bit in recent years. One of which is, as we talked about, the patient population, that if they have a mismatch repair mutation, that may be a candidate for curative therapy with immunotherapy alone, which is, very exciting. You could spare somebody an operation that is very impactful on their quality of life. So another thing we think about is, are we going to be able to preserve the anal sphincter in a rectal cancer patient? So if a patient has ingrowth in the sphincter at time of diagnosis, or there's any level of major baseline incontinence, or if the tumor is close, it's important they're educated that we may have to take all of that out. That does result in a permanent ostomy bag. And that's a difficult thing for anybody, to come to peace with their mind and heart, but that can be, more problematic in a patient that's young. Additionally, I think as surgeons, sometimes we look at numbers and we congratulate ourselves when we have something that's numerically successful, such as a treatment for cancer that has a high cure rate. But we got really excited about being able to preserve the anal sphincter about 20 years ago for rectal cancer, meaning with treatment changes like radiation, we oftentimes are able to shrink tumors in a way that we could remove the cancer without giving a person a permanent bag. And some of that was related to our treatment, as well as advances in technology that allowed us to reconnect the bowel. The downside is losing the rectum is no walk in the park. And I tell people that you're probably going to hate me for a while after this, and this is going to be a permanent change to your quality of life. The rectum's a pretty smart organ. So it's a storage container, and it has the ability to help us discriminate between gas, liquids, and solids. The more of that you lose, the smaller your container gets. You then treat it with radiation, which causes it to be less compliant and fibrotic, so it doesn't work as well. And then also by getting radiated, the ability of the rectum to let you know whether you're going to pass gas or have a liquid or solid bowel movement gets compromised. So you can think what happens when you remove the rectum, and even if you can successfully connect the colon to the anal rectal remnant, oftentimes they do develop what's called LARS, or low anterior resection syndrome. That basically means they feel like they have to poop all the time. They have to go, and it is right now. They go and they feel like they haven't gotten it all out. So they'll basically spend an hour or two in the morning just kind of trying to get the relief of completely evacuating. They may be waking up at night to go to the bathroom, and that can be a pretty big deal because sleep deprivation can lead to other morbidities. They may have to wear some type of undergarment. They may end up with permanent sexual dysfunction. So these are really big deals. You look at someone and think, I did this to you, and yes, we can say it's successful from a cancer standpoint, but it's a very morbid thing that you have to learn how to adapt to. And so, in the interest of time, I'm happy you guys are more than welcome to keep these slides if you'd like to look at this further. So the long and short of it is, for very, very early stage rectal cancers, sometimes we can just do surgery up front, but for most part with rectal cancer, we do actually treat them with chemotherapy and radiation first if they're garden variety, microsatellite, stable, not mutated patients. So what that means is they get all the FOLFOX and radiation prior to deciding on definitive treatment. And that some of that comes from the Memorial Sloan Kettering experience, where they learned that you can preserve the rectum in a fair amount of patients safely, meaning, say I have a patient has stage 2 rectal cancer, they get chemo radiation. What we do is we let them go through that treatment, then we wait for about a month and we restage them. We do repeat endo and exam, and about 20 to 25% of them, the cancer disappears, which is really exciting, because then that raises the question of, well, do we have favorable biology? And if the cancer otherwise appears to be in remission, do we have to go forth with a big operation that's going to be very impactful to quality of life? And what we know is about 80% of people who have rectal cancer that are mismatch repair stable, that totally respond to chemoradiation, will go on to be cured long term. So that's pretty darn good. So that's another option for patients, but it's important they're counseled that curative resection may give them a 95% chance at cure, but then you have to deal with the aftermath of surgery, versus if this totally vanishes, you may actually have an 80% chance that you stay in remission long term. And so watch and wait is what you may see in some of our notes. And watch and wait just does refer to the patient population who get their chemotherapy and radiation up front, and whom meet remission criteria by having nothing present in imaging, nothing you could feel in exam. You could almost always feel cancer because it's hard. and nothing that's visible endoscopically. So if a patient, qualifies for this, we just offer close surveillance, which means every 3 to 6 months, they're coming in to get images, endoscopy, and exams. The downside to watch and wait is we do get excited about, being able to spare people morbid surgery, but it can fail. 20% obviously is not zero. And it's possible that when it fails, it may not be resectable, or the failure may manifest as metastatic disease, meaning, 2 years later, there's a tumor in the liver. And briefly, in regards to rectal cancer, this is where I think the biggest cutting edge and excitement and, the treatment of colorectal cancer currently lies, is the studies that show that if you're deficient in mismatch repair or microsatellite high, or have the POL1, POL-D1 mutation, these patients have such a high response to immune therapy or checkpoint inhibitors. The remission is just slightly under 100%. So this is a pretty big, I think, advancement for us. So it has actually become the first line therapy in a lot of rectal cancer patients who are, candidates for such, and it is the first line therapy for metastatic disease. Immune therapy is not totally benign, but it tends to be pretty well tolerated as well. Other thing I think it's really important as a surgeon that I, talk about with my patients is the understanding that with rectal cancer, you're in it for the long haul. I know I like results. I like to get stuff done fast. And I, feel like a lot of my patients, feel like, man, I've been going through this for months, and when can I move on from my life? So with rectal, we know that it takes us a while just to get the workup and staging. So sometimes that's a few weeks. And then if we do upfront chemoradiation, that can be in the up range of, 4 to 6 months to treat, because they'll get systemic chemo, usually 9 cycles of it every other week. So that's, 4.5 months. So now, say you get diagnosed in January, you're talking about finishing chemo and radiation in the late spring. Then we let you have a break for a month and restage. So then we're into early summer. And then if you need to have surgery, we're doing surgery. Oftentimes, surgery does require a protective ostomy to let things heal. And then it usually takes about 3 months for any type of rectal anastomosis to heal to the point that we can reverse the ostomy. So from the day you get diagnosed to the day that, you can start to move on from it and go into a surveillance program is 6 to 9 months. So I do tell patients this is frustrating, and it will take a very good chunk of your year. And this just refers diagrammatically what low anterior resection means. And it just basically means taking out the mid-lower rectum. And in some cases, you may be able to attach the colon to the anus, depending on tumor location. In ileostomy, although why we're protecting it in this picture is not the same, but a loop ileostomy is oftentimes done in this patient population. The reason for that is we know that the colon to the anal anastomosis in itself has a healing rate that fails about 15 to 20% of the time, but you throw radiation into that, healing is a problem. So what you don't want to do is put someone together and know that there's probably a 20+% chance there's going to be slow healing, and then have a leak of stool in the pelvis that's got all sort of negative short and long-term implications. So what we do, we put them together, we let them have a loop ileostomy. So stool basically gets diverted for about 3 months. And if they're going to heal, they almost always do within 3 months. But then that also means you're coming back for surgery number 2 at that point. Another thing that if you get a patient in your clinic, if you see abdominal perineal resection, they probably don't have an anus. Now, granted, I know unfortunately sometimes stuff may get misworded in notes, but if a person truly had an abdominal perineal resection, that means they had a low rectal cancer in which we had to take the anal sphincter to get it out. That does result in a permanent colostomy bag, but it also means that their anus is cut out. So we make a cut around the external sphincter. And so this is also shut. So if you ever examine them, then just anticipate there's going to be a scar back there, and they're going to have a surgically absent anus. And then lastly, I think specific to the young patients, that's really, really important to consider is what's the consequence of chemo and radiation to fertility and quality of life. Interestingly, fluorouracil and oxaliplatin is not that much of a problem for fertility. Immune therapy has a potential risk, though. And what we do know is radiation is a really big one. So if a young lady has rectal cancer, you can anticipate permanent damage to the ovaries and uterus and infertility. You can do things like ovarian transposition, which means a gynecology doc can go in minimally invasive and kind of tack up the ovaries to get them out of the pelvis so they don't get damaged by the radiation. You can preserve eggs or do embryo freezing, but that involves harvesting and time commitment, and that's not always financially affordable for a lot of patients. It can be in the up end at $10,000+. There's also some interest in hormonal preservation, but with that, of course, you have a cancer patient that in themselves has a higher risk for thromboembolic events. The HRT, that's, also something that we have concern about. Males also in a different way, but they can do sperm banking. It's not quite as expensive. Chemo is not as much of a problem with them. So maybe if it's like my patient that I operated on, the young firefighter, he had to go through this. He chose to do sperm banking, but he only needed to have fluorouracil and oxaliplatin, but he wanted to be on the safe side. That being said, oxaliplatin usually is just transient, meaning long term they should, have fertility improve. But that being said, if they need to have immune therapy or radiation, that can be a bigger deal. Testicular radiation effectively can lead to impotence, fatigue, libido problems, reduced sperm count. So all these things, it's patients survive it, but it's their life after treatment is oftentimes very different than what they were used to prior. When we do surgery for rectal cancer too, all the nerves that help us do things like empty the bladder appropriately, have appropriate ejaculatory function, and sexual function can get damaged. So there's one nerve that runs very close to where we have to dissect the mesentery, that if that's damaged, they'll get retrograde ejaculation. And if you damage some of the nerves deeper in the pelvis, that can lead to impotence. So, and that actually can be up to 50% in regards to at least being transient with, a smaller number, but still a fairly high number that go on to have that be permanent. And then lastly, metastatic cancer, management of metastatic disease. It is important to tell patients this is not necessarily a death sentence. It may be something that we can't cure, but you may get to enjoy quality of life for several years with stage 4. So not only do we have chemo, there's some more, kind of aggressive chemos that are added on for young patients. They can tolerate these things. There's clinical trials. There is kind of an evolving benefit known that we associate with surgical debulking. When I trained, that was thought to be a big no-no, that there is no benefit to that. But in select cases, sometimes they can be debulked. There's a lot of great liver-directed therapies now. So, we're pretty aggressive with offering resection. You can do hepatic artery infusion pumps in which the chemo goes just straight to the liver and spares the patient from some systemic side effects. You can do IR-directed therapy, and we actually have done transplant in this institution. So some very select patients with oligometastatic disease of the liver from colon cancer may actually be a transplant candidate. Cytoreductive surgery or HIPAC means you scrape any type of small cancer deposits and administer abdominal chemo. And in select patients, they can be candidates, as well as cancer vaccines and targeted therapies. Other things we spoke about a little bit earlier is the concern for psychosocial issues with stoma, the side effects of chemo, in particular neuropathy and fatigue, and also noting that oxaliplatin-based neuropathy can be permanent. And then also thinking about what is the psychosocial and financial implications. You have young people that are maybe they have a mortgage and they can't afford to not work for months to keep their head above water. They may have children they're taking care for, may have elderly parents. So some of the social issues can be really pretty profound in this population. And I'll just, in the interest of time, one thing I always like to talk about with patients is, I love this quote. I heard it from a colorectal surgeon years ago about, it's one story to save somebody's life, but it's another story to make them glad that you did. So I think with these operations and the recovery from these types of treatments, it's a big deal, and it's it really can be very impactful to some people. So I'm very enthusiastic about support after the proverbial tornado is passed with these folks, and spending time with them when they come back to our clinics and undergoing surveillance, and really touching base and trying to elucidate what their quality of life's like, and being aggressive at offering interventions to try to help make them as functional as possible. And lastly, just to summarize all of this, if I always tell people, if 2 and 2 equals anything other than 4, think the worst and be surprisingly happy when it's the best. So I have a low threshold to offer colonoscopy. I think healthy lifestyle, that sometimes really getting down to the root cause is the most difficult thing, but encouraging a healthier lifestyle, both when it comes to dietary, social choices, exercise from a young age is very helpful. And I also think there's something to be a truth to be said in the quote of, we don't know what we don't know. Is if you don't know that getting cancer in the colon is a possibility at 30, you don't suspect it. So I think trying to educate as many as possible that, while uncommon it can happen, does at least put this on their radar. And then also bear in mind that young patients are more likely than older ones to show up symptomatic. So they may already have something going on that should kind of raise the red flag. And then lastly, we know that early detection, the survival and long-term cure rates, if it detected early, is dramatically better compared to late. So being proactive is certainly helpful. And this is me. Anybody is always welcome. You want to just talk about this, shoot me an email, give me a call, text. I'm always running around all over the place. But that being said, I return texts and phone calls as soon as I possibly can. And it would be a total pleasure and privilege to get to work with all of you. So please keep my contact and don't hesitate to contact me. I am happy to talk about any questions or talk about anything you like in regards to this topic.
Thank you so much, Dr. Logue. That was fantastic. I know that I did lose a sister-in-law to colon cancer at the age of 38. So, yeah, it is definitely great information. Does anybody have, I know we're a few minutes after. Does anybody have a question for Dr. Logue before we say thank you again? Thank you so much. It was a great
Dr. Logue,
presentation.
I do have a question. I
Yes.
I hear the importance of having fibers and fruits and vegetables as part of the daily diet, but I've also met patients that do not eat vegetables. Is there a place for like fiber supplements? Because I've asked them like, where do you get your fiber? I said like we take fiber supplements. Can you comment on that, please?
Yes, I like to tell them, some people think this is kind of fun. So if you get Metamucil and there's a scoop, you just basically take the scoop, you mix it in a shot glass, just enough water to solubilize it, shoot it down before you go to bed, drink a glass of water after. That oftentimes will work like magic. So some people, I think, just kind of have fun with the whole, yeah, I can shoot my Metamucil down. So that's one option. It's interesting. Metamucil and a lot of the fiber products will, kind of advertise themselves as they don't have any taste and they're, really don't cause symptoms. But we're all different, and I definitely, give patients credibility and they say, hey, listen, this hurts my stomach. I hate it, or I hate the taste. Other alternatives, they can get fiber gummy bears, which can be very helpful. We think that obviously you don't get the same bulk with the gummy bears, but it's better than nothing. And I do like to be creative in regards to telling them other things they may like that, they could incorporate in their diet. Especially if they're dealing with stuff like constipation, I tell them, we always think about stuff like prunes, but you could try papaya. Papaya is thought to be a superfood, and some people will be able to get creative with that in shakes and find it very palatable. Interestingly, yellow dragon fruit, that can be a miracle in regards, in particular, to treating constipation.
Thank you so much.
You're
I'm
welcome.
all about the fiber gummies.
Yeah, I think they're great. And I feel like, what, it's better than nothing. And if that's something somebody finds palatable, that's awesome.
Thank you. I think there
Pleasure.
was just one chat from a retired U.S. Coast Guard
Yeah.
that just watch and wait, had 2 screenings and recent Cologuard recovery, several old bullet wounds, shrapnel destroyed my gallbladder but grew back luckily. In the service had to wait and taste for sugar and meat, went away but became fish and poultry, love catfish, veggies, and taking iron now 75, is practicing Aikido and Tai Chi and have a garden. So thank you so much.
You're welcome. No, I thank you for sharing that story. I'm with you. And it's funny, the older I get, you realize it gets the small things in life of what really make you feel good. Being able to sit out in the garden, do your work, or take a walk and just feel the sun on your head and observe nature. Sometimes that could bring you a lot of peace.
Thank you. Ms. Turner, do you have a question?
Yes, I do. Actually, two questions. What's the difference between cancer and tumor? And I got removed 3/4 of my column, and I didn't know it's a cancer or tumor what they did to me.
So I would define, and sometimes they'll use these words in ways that can be very confusing. So sometimes they'll say, well, you have a colon mass. So what is the difference between a mass that's benign versus a mass that's precancerous versus a mass that's malignant? So sometimes you'll be told that you had like some type of a mass removed from the colon, and it may be a polyp. oftentimes in the colon, it will come back as something like an adenoma. And if it just states that, that actually means it's a polyp. Now, do all polyps develop into cancer? Not all of them do. So that it's possible that's, one manifestation of a mass. Alternatively, if you may get something removed from the colon in which they say it's high-grade dysplasia. High-grade dysplasia means the polyp is starting to develop damage, meaning it has some mutations, and if left go for long enough, it may continue to acquire more mutations that will give it the features to make it a cancer. So if you see dysplasia, that means it's not cancer yet, but it's starting to go on that route. Cancer basically means there's cell changes, meaning things have accumulated and damage over many years that allow the mass or lesion in the colon to potentially spread someplace else, meaning it can get into the lymphatics or the bloodstream. And if you see the words invasive or carcinoma, that would imply that the histologic changes have taken place that give it the ability to spread. And that's really what defines cancer, is the ability to spread elsewhere.
Yeah, okay. Because when I had my surgery, it was a several removal organs, but one of them, it was a 3/4 on the column, and they say that how I kept it all in one circle, like a size of a grapefruit. And I was like, I don't know. I just know God has been wonderful. But the doctor told me, the surgeon told me, only every time I need to go restroom, and I have to only 10, 15 minutes to go to the bathroom every time I have the feeling. So not to hesitate and to just go ahead, and you have to go. Go when you feel it. Don't hold it, or in that case, yeah, something's gonna happen. So I was like very conscious about that. I don't wait too long when I need to go to the bathroom.
No, thank you for sharing that story. Absolutely. And it sounds like based on what was removed, there could have been, enough in the area of the bowel that would cause, that type of alteration in bowel habits. And yes, with that sometimes just comes to that urgency where you think, I gotta go. And it's, yeah, exactly. And getting to understand your body, and, when you get that sensation, know that you have access to a restroom it's very important.
All right. Thank you.
You're welcome.